All right, here we go. Let's talk about the evolution of lung cancer care, which I see as a divergence to both larger population health management and molecular level personalized medicine. This is the tale of two paths from what I can see. These paths involve a change from really a focus on organ-specific treatment of lung cancer to one, a broader population health management involving lung screening, patient education, care coordination, and data, versus a personalized genomic medicine which uses information from patient-specific genomes, such as RNA, cell-free DNA, to guide medical decisions. So you're looking at how do we bring healthcare to the masses versus how do we make it specifically better for each individual. So this is the only slide I have as a carryover from last year's talk. Yes, I am a damn Yankee. That's my disclosure. Just so everybody's clear on this, a regular Yankee is someone that's born in the north but comes to visit but returns home because they like the crappy food and the cold weather. Damn Yankee like me comes and stays because of the nice people, and a GD Yankee is a Yankee who comes south, marries a southern girl, and teaches her and the kids to behave like northerners. Shameless. So, as we move on, timing is everything. We're at a critical moment in healthcare delivery. The transition to value-based payment, political and policy uncertainty, affordability, and access to good healthcare is challenging patients, providers, payers, communities, and systems. Scientific breakthroughs have been made now to enable us to determine whether lung cancer has a specific targetable genetic mutation from an office blood test. The Institute of Health Improvement lets us know that there is a growing realization that the successful healthcare systems of the future will be those that can simultaneously deliver excellent quality of care at optimized costs while improving the health of the population. This is often referred to as the triple aim of population health management. If you look at this diagram from the Commonwealth Fund study, the USA spends more than any other country on healthcare, but the survival rates are actually a little bit less than most of the other countries. So why are we spending so much but not have great health like everybody else? Either we're not spending it the right way or we're not educating people the right way. So this needs to be addressed and looked at. Of course, we are a population of smokers. You know, when Lucy and Ricky tell you to grab a pack of Philip Morris's for many years, it's hard to avoid. So some definitions of population health. This one from CEA Wilson from Yale felt that the science and the art of preventing disease, prolonging life, promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals is what this is all about. And that's fairly broad. But once again, when we were told from a child that, you know, if it's cool for Fred and Barney to smoke, how bad could it really be? This gets ingrained in you. A more up-to-date definition from Wellcentive is population health management is the aggregation of patient data across multiple health information technology resources, the analysis of this data into a single actionable patient record, and the actions through which care providers can provide both clinical and financial outcomes is going to help the population. Of course, this guy right here, if he's saying it's cool to smoke, hard to argue with Yule. He's got some interesting lung cancer videos later in life. So let's look at the McKesson Technology Solutions diagrams and way they describe a population health model. It should include both connecting, analyzing, intervening, engaging, and support. So the connecting part. This involves acquiring, aggregating, and leveraging data in support of clinical integration is going to be the base requirement for providers seeking to participate in population health management. Organizations must build a foundation on sharing data with practice management, systems, claims, laboratory pharmacy, and electronic medical records. Analyzing that data. Once connected and the data is achieved, it's got to be turned into usable information. So these organizations are going to have to strive to share the data analysis with all of these systems equally across the board. So clearly data is the future. There's no doubt about that. And sharing is also going to be critical to making improvements. So the analysis of this data could help in predictive modeling to stratify patients by clinical and financial risk so that the appropriate level of care can be put towards the higher risk patients. Also, cost and utilization across illness episodes and specific medical conditions to give a full picture of this high risk patient. Identification of patients that are not compliant and patient registries to track data. In addition, provider practice patterns need to be identified so that outliers and education of delivery evidence-based medicine that's cost-effective can be made available. Network analysis regarding leakage, opportunities to optimize network performance, and certainly physician incentive programs. All of this needs to be put together so that an intervention can occur. Population analysis identifies members of the population who require intervention, whether that means closing preventative or chronic care gaps, as they're referred to, which means lack of care, or generating a plan or addressing what keeps a person from filling a prescription or taking their meds. Engagement. Population health model says that there should be engagement on 3 levels: patient, physician, and other clinicians, and the provider network. So let's look at these engagement steps. Patient engagement. This signifies that a person is involved in a process of combining information and professional advice with his or her own needs, preferences, and abilities in order to optimize their health and the healthcare decisions being made. Strong patient engagement is about activating, educating, and involving patients in their care to produce better clinical outcomes. I'm a big supporter of this, and as Ben Franklin said, tell me and I forget, teach me and I remember, involve me and I learn. We need our patients to learn what's going on with them. We need them to be able to participate. Tools to help with this: outreach, extension of care management, patient education, and behavioral change. I think these things are very critical. Offering tools and available content that educates patients about their condition and encourages their informed, active participation in decision-making is very vital. And I think that that is going to be a very powerful tool for us. I truly believe, as this says, that the most important member of this healthcare team is on the table right now. Shouldn't they know as much as possible to help make those critical planning decisions that affect their health and the rest of their life? We need to involve these patients. I'll talk a little bit later and show you my website that's dedicated to educating patients about lung cancer care, the evaluation, the diagnosis, and treatment options. People need to know. So, engagement of physicians and clinicians. They need to buy into this. Alignment is going to be key. They need to know the metrics that they're going to be measured on. They need to understand this and be involved. What's really important is that workflows have to be created to achieve these right outcomes. The right information must be available to the right person at the right time. And providers themselves. The network engagement involves proactive steering of patients to the most appropriate lower cost care setting for the clinical need without compromising the quality. We need to have intelligent utilization of resources. These should be analyzed and encouraged. Clinical pathways must be looked at to determine which ones achieve the best outcome with the least cost. So if there's some examples of this, a strong network management would say, let's encourage a patient with the flu to go to urgent care rather than go to an emergency room. We should also be analyzing the treatment of various stages of lung cancer. We know that early stage gives a better survival, but this takes resources to screen and to follow up. Is this cost effective? Well, my friend Tom Gilday and Kyle Hogarth and Dave Wilson and I have just published a paper in Clinical Economics looking at this. Lung cancer is usually diagnosed at late stage because it often has no symptoms until it has spread. Late stage diagnosis lowers the chance of survival and may increase cost, but little data is known about this. So we had access to a large data registry. Patient data was retrospectively reviewed from the Cancer Registry of the Optum Oncology Management Database, an administrative database of medical and pharmacy claims from a large U.S. health company. Commercially insured adult patients who were diagnosed with cancer from 2007 to 2011 were reviewed. They had similar survival and diagnostic rates as seen nationally. So of the 5,128 total patients reviewed, 3,000 of them met the continuous enrollment criteria. They had to have data all the way through. 3,149 had complete staging. Of those, 1,507 had both medical and pharmacy benefit data. 80% of those were non-small cell lung cancers, 1,210. So cost analysis was separated into pre- and post-diagnosis for those patients. So when this was analyzed, the only real differences seen were cost per stage. As you can see here, there's a progression of increasing cost with advancing lung cancer stage. Clearly, almost 3 times as much of stage 4 compared to stage 1 lung cancer. Interesting, the cost to diagnose it was pretty much reasonable across the board. And this was studied from patients all over the country. So in summary, it's a retrospective analysis. The key points that it showed were that in more than 90% of the patients, there was a long delay to make a diagnosis from time of an abnormal chest x-ray. That needs to be improved. And although the cost of diagnosing the lung cancer was similar, the cost of treating was much higher for patients with stage 4 cancer, around $21,000 per month, compared with stage 1, which is only $7,000. These results highlight the value of diagnosing lung cancer not only to increase the chances of survival with early stage, but also reduce healthcare costs. Hopefully this information will improve the acceptance of screening programs with primary care physicians, networks, and payers, promoting population health. So the last aspect was support. Provider networks must make substantial investment to support the transformation to a value-based. This means we need people, data registries, personnel. These services will lay the foundation for care models, care teams, payment, and organizational processes. But as we all know, change can be hard to swallow, though it is inevitable. I think that what's important is what Charles Darwin said. It's not the strongest of the species that survive, nor the most intelligent, but the ones who are most adaptable, who are responsive to change. That's how we're going to survive. This is a hot topic. And Mayo Clinic, in fact, in just a few weeks is having a meeting regarding just this, closing the gap between people and healthcare, population health medicine. So, in summary, for population health medicine, the triple aim is improve the experience of medical care, quality and satisfaction, improve the health of the population, and reduce the per capita cost of healthcare delivery. This is clearly necessary to improve outcomes with the resources we have available, though it doesn't sound too personal. So let's switch at this point in time and go down another pathway. Let's get small, shall we say, and look at personalized medicine. This is often referred to as genomic medicine, and this is also a very hot topic today for many different reasons. So personalized medicine also has the terms stratified medicine, genomic medicine, P-form medicine. This is a medical procedure that separates patients into different groups, with medical decisions, practices, interventions, and/or products being tailored to the individual patient based on their predictive response or risk of disease. That's from the Academy of Medical Sciences. Diagnostic testing is employed to select appropriate and optimal therapies based on the context of a patient's individual genetic content or molecular cellular analysis. The use of this information has played a particularly valuable role in the aspect of personalized cancer care, such as oncogenomics regarding the choice of chemo. This can be referred to as pharmacogenetics. You've all seen some of these drugs already being used in breast cancer. As far as lung cancer goes, it still remains the most lethal malignancy in the world. Despite improvements in surgical, systemic, and radiation therapy, the 5-year survival for all patients is only 16%. With biomarker identification, new therapy strategies for targeted therapies have come into play to improve survival. Mostly these have been indicated in advanced stage lung cancer. If you look at the biomarkers available for lung cancer, EGFR, which is one of the first ones identified, if found, can be treated with EGFR TKIs such as Tarceva. It does not occur in more than roughly 15% of the adenocarcinomas, so it's not a high percentage of the lung cancer patients that can be effectively targeted. The other biomarkers often determined from the pathologic specimen are the ALK, anaplastic lymphoma kinase gene rearrangements, MET and ROS1, similar to the ALK, and KRAS, which interestingly occurs more often than most of the other ones. To date has been elusive to develop a targeted therapy towards that. However, when present, it has shown in one study to have poor response to radiation therapy. So the difficulties with the biomarkers are that they do not occur frequently, these mutations. Significant amount of tissue in the past has been needed to process them. So sometimes just a regular lung biopsy has not always been enough, but the pathology departments are getting better at this all the time. And sometimes it had taken weeks to get this. That also is improving somewhat. What's very interesting is that just about a year ago, the FDA approved the first blood test, or liquid biopsy, to detect gene mutations associated with non-small cell carcinoma. So with a simple blood test, EGFR can now be detected in 72 hours in someone's bloodstream. This is from DNA that's cell-free, circulating. What this does is it uses a technique of droplet digital polymerase chain reaction test, PCR, to screen for tumor-derived cell-free DNA in the bloodstream. EGFR, ALK, KRAS mutations can be back in 3 days. Also, it can look at IL-6 and IL-8 levels that will reflect the aggressiveness of a cancer. So these blood tests can be used not only to determine if you have the mutations, but as you're being treated, progression of EGFR levels can be monitored. Obviously, an early positive test will certainly push for a repeat biopsy if you don't have a diagnosis, and a KRAS mutation may push us towards more of a surgical resection rather than radiation therapy. In addition, messenger RNA can be sampled from the bronchial airways, looking for the expression of 23 genes, including 17 cancer genes. This is done in high-risk smokers, can be done during a regular bronchoscopy with just simple brushing of the airway. This is the Percepta bronchial swab test. And the epithelial cells in the upper airway, this is not biopsying the cancer, this is biopsying cells in the upper airway that may have messenger RNA that can be associated with a high risk of cancer. If it's positive, it correlates well with the presence of a cancer. If it's negative, it also correlates well that your lesion may not be cancerous. So now let's look at immunotherapy. This is the use of drugs to stimulate a person's own immune system to recognize and destroy cancer cells more effectively. This is the ultimate personalized self-medicine. The drugs available right now for this are Opdivo, we've all seen the TV ads, Keytruda, Tecentriq. All of these have been approved basically within the last 2 years. These are very exciting drugs, and this is a good time for lung cancer. So, immunotherapy. The Opdivo and Keytruda target a PD-1, a protein on the immune system of T cells that normally helps keep these cells from attacking other cells in the body. By blocking this PD-1, the drugs boost the immune system so that it can fight cancer cells. This drug can shrink tumors and can slow their growth. Tecentriq targets a PD-L1 protein similar to PD-1. All these drugs are given as an infusion. PD-1, which is a programmed cell death protein, as I mentioned, is a cell surface receptor that plays an important role in the downregulating of the immune system, promoting self-tolerance. So it's a checkpoint, and it guards against autoimmunity. The PD-1/PD-L1 pathway is an immune checkpoint. Immunotherapy works by inhibiting the checkpoint. So here you see the red T cell is shut off when the cancer cell delivers into the PD-1/PD-L1 receptor site. So if that receptor can be blocked, the T cell can be turned on in the green color, and then the T cell can do its job by identifying the cancer cell as not normal and trying to kill it. This is the basis of immunotherapy. Who benefits from it? Well, patients with the highest level of PD-L1 expression, as determined by tissue biopsies, have a greater chance of having immunotherapy work than chemotherapy. But only 30% of patients with advanced non-small cell lung cancer have a high level of this. If the biopsy doesn't show PD-L1, some people still may respond to it, so science is still working out the details of that. Keytruda is now approved by the FDA for first-line treatment of patients that do have PD-L1 expression in over 50% of the cells. It's also approved for follow-up treatment if they just have a small amount of PD-L1. Now, patients have fewer side effects with immunotherapy than chemotherapy, but there still are side effects, mostly sort of an autoimmune side effect. Researchers are also looking into whether using immunotherapy in combination with chemotherapy can improve overall survival, or immunotherapy with surgery and radiation therapy can improve cure rates with early-stage lung cancers. Also, what's interesting is hopefully by early next year, the liquid biopsy testing will be able to determine PD-L1 levels, again, by a simple blood test. This is a recent study out from the New England Journal at the people at Ohio State. It was a phase 3 clinical trial showing improved response rate in 75% of patients given Opdivo who had both high tumor burden and a high PD-L1 level. If they didn't have both of those, there was no improvement compared to chemotherapy. So it still is a smaller subset. However, this gives hope. Hope begins in the dark, the stubborn hope that if you just show up and do the right thing, the dawn will come. I believe hope is the strongest tool in our medical box. And again, not to be behind the times, Mayo Clinic next month in October is having a meeting now regarding personalized medicine, precision medicine. This is a hot topic. So if you look, you've got public health management, you've got DNA evaluation. You've got these sort of two pathways. One is looking globally, one is looking downstream. It's a different allocation of resources. And so you say to yourself, should we focus on one path or the other? Well, as Robert Frost did, two roads diverged in the woods. I took the one less traveled by, and that has made all the difference. Well, genomic personalized medicine, big bucks versus population health management. I'm wondering, do we have to choose? What does Tony Stark say?
I say, is it too much to ask for both?
All right, let's go to our last topic and switch gears. Let's update on lung cancer staging. So we're going to look at the recent changes from the AJCC 8th edition Lung Cancer Staging Manual, which will come into effect 1st of 2018. I've got here is the 2017 diagram that I sort of used to try to put together a quick reference on staging using the TNM system. My website has a full explanation of the overall TNM system, which is a little bit boring unless you're in oncology. However, you can go there to look at that. But some of the changes in general, We went from 6 T classes now to 9 overall T classes. The T1 changes, T1, TMI was added, TIS was added, and then T1 was broken down to an A, B, and C class, so that there are now 5 levels of the early T stage. When you look at the T2 stages or classes, these were changed. T2A used to be 3 to 5, now it's 3 to 4 centimeters. T2B used to be 5 to 7, and now that's down to 4 to 5 centimeters. So then this change reflected upward to the T3 class. So now the T3, which used to be a tumor greater than 7 centimeters, is now a tumor between 5 and 7 centimeters, still though invading the chest wall, diaphragm, or pericardium, or a separate tumor nodule that is occurring in the same lobe. That's now going to be a T3. T4 from this used to be a tumor any size, but now it's a tumor classified greater than 7, but still has the description of having separate tumor nodules in the same lung but a different lobe, ipsilateral lobe, or mediastinal invasion, or diaphragm, esophagus, or vertebrae. The nodal class N1, N2, and N3 is diagrammed here. There was no significant change in this classification. The M classes, M1A still is a tumor in the contralateral lobe, or pleural effusion and pericardial studding, but the M1B now has been subdivided. It used to be any distant mets. Now it's only a single met to a single organ, which then leads to M1C, which is either multiple mets in a single organ or multiple organs. So the new stages that were added from this 8th edition are the stage 0 for the TMI. Now there's a stages 1, A1, A2, and A3. There's a stage 3C, and stage 4 is divided into A and B. So if you look at the handout that I've given, now this is an updated diagram which I use to try to quick reference the TNM system. You can see when you compare it to the older system what stages have been added and what T and M classification changes have been made. If you go to my website, I have a, as mentioned, long, somewhat boring video that has diagrams and X-ray images of each of these classifications. So I think these subclassifications were made because lung screening evidence shows early stage lung cancer has an improved survival. You look at this 1A1, 1A2, these are the early lung cancers that we have to find. This is critical. If we're going to improve overall survival, you got to screen. More than 430 people die per day from lung cancer. That's like a 747 falling out of the sky. So we know lung cancer screening saves lives. We've got some data that shows it's going to save money. So I say, let's find it now. We really need to push lung screening, lung cancer awareness. These things are very, very important. So this is my website that I've mentioned. It's up and running. I'm populating with additional videos and information each day, both for clinicians and for patients. I want to share with you sort of a little preview of one of my other projects on this site, educational for lung cancer patients. I interview patients to see how they quit smoking. This is a brief clip. Here we go. Okay. We're with. So no names here, but they're going to know instantly you're a New Yorker. So that's going to come out. A good friend of mine here. Tell us your smoking history and how you quit.
Started about 17, 18 years old for many, many years.
So here we are with a lovely Irish lass. So how long did you smoke for?
I smoked since I was 16.
For how many years then?
26 years.
All right. Pack a day or?
Oh, yeah, more on the weekend.
More on the weekend, okay.
Yeah.
So here we are with our good friend, Mr. Dan Smith, who's a lung cancer survivor.
That's it.
And you've had a bone marrow transplant.
Yes, I have.
That was for your multiple myeloma.
Multiple myeloma.
So you're a double cancer,
That's it.
kick-ass survivor.
Oh, yeah.
Good man. How did you were a smoker.
Yes, I was.
How long did you smoke for?
35 years.
Pack a day?
Pack a day at least.
All right. How did you
That
quit?
causes to start again.
Okay. So how'd you quit the second time?
Cold turkey.
You just offed it.
Popped it.
Boom.
That, bam.
And nothing, you haven't smoked since?
No.
Okay. Didn't work.
Didn't work.
Okay.
Eventually it was stuff called Smoke Away.
Smoke away. Okay.
Smoke Away, which I ordered online, and it was an A bottle of tablets and a B bottle of tablets.
Yeah.
You took the A tablets for, I think it was a week before you were ready to quit,
Okay.
and you took the B you continued to take the A tablets for another 2 weeks, and then you took the B tablets if you needed them for support after that.
Afterwards.
I never even took a B
Never
tablet.
took a B tablet.
But the key, I think, was the little vial of some kind of herbal mix. I don't know what it was.
Okay.
But you'd sniff this
Really?
whenever.
Wasn't a white powder.
No, it was
Okay.
not white powder. You just
Pack a day at
sniff.
least.
All right. How did you quit?
When that man told me I had stage 4 cancer and wanted to know how long I had to live, that's a good indication you better quit smoking.
Right there.
Right then and there.
You did not have another one.
I did not have another cigarette.
And you've not had another one since.
Nope. Want them, but no better.
We're almost 2 years, right?
Oh, yeah.
About that. Just
Yeah.
about. So I just want to throw in my opinion of what personalized medicine means, certainly to me. If you've got a lung cancer, it needs to be found, it needs to be classified. Tumor-specific DNA mutations that may exist need to be looked for. You need to be educated on your cancer, the stage, the prognosis, the available treatments, how those treatments will affect your physiologic, your social status, what's the potential for cure, what's the risk, what's the benefits. The goal is to preserve life and its quality, and I think patients need to participate and be involved. I just want to thank everybody very much for taking the time to listen to all of this and be here. And I truly believe anything is possible until your last breath. Make each and every one count. And probably the best thing that I've heard in a long time is this one. Sometimes it's necessary to go where the Wi-Fi is weak, but the rum is strong. Thank you again. Take care.